You are listening to Speak Up and Stay Alive Radio. I am Pat Rullo, your hostess and author of the book, Speak Up and Stay Alive, the Patient Advocate Hospital Survival Guide. If you've listened to this show for even 1 minute, you know that we are dedicated to the promotion of patient and family engagement during every healthcare and hospital encounter. That's why when I met today's guest, be it online, I just knew that I had to share their efforts with you. Many times we wonder, does the patient or the patient's family really have a voice? Does what we think and say matter to anyone? Well, some hospitals around the country think so. Today we have two guests, both involved with a hospital project that actually includes the patient voice. They are from Beth Israel Deaconess Medical Center in Boston, Massachusetts, the Harvard Medical School Teaching Hospital. First, we have Barbara Sarnoff Lee. She is the Director of Social Work and Patient Family Engagement at Beth Israel Deaconess Medical Center in Boston. She is responsible for the strategic planning and operational development of patient family engagement activities, which includes the creation and facilitation of numerous patient family advisory councils, the placement of advisors on various medical center committees, and the development of topic-specific focus groups. Barbara has served as faculty at Harvard Medical School, Simmons School of Social Work, and Boston University School of Social Work. And our second guest is Elana Premack Sandler, and she is the project leader for the patient family engagement at Beth Israel Deaconess Medical Center. Elana manages the activities of over 100 volunteer advisors. In her role, she looks for ways to increase opportunities for patients and family members to be involved in hospital process and quality improvement. Elana has taught at Boston University School of Public Health. Well, we've got a powerful twosome. Thank you both for sharing your time with us today.
Thank you. Thanks so much.
Beth Israel Deaconess Medical Center is bringing patients and families into the hospital's decision-making processes related to quality and safe care. So with that in mind, what made you decide to address patient-family engagement?
This is not new for us. In the 1970s, what was then Beth Israel Hospital created the first patient Bill of Rights, and in the 70s, also one of the first do not resuscitate policies, both of which then served as a template for the rest of the country. In the 80s, the Picker Institute was born at Beth Israel Deaconess, and Dr. Tom Delbanco and his colleagues were among the first to recognize the importance of engaging patients through surveys and focus groups for continuous learning, and then getting them involved in new approaches to care. In 2005, our neonatal ICU started a patient advisory council, and then in 2007, we started an adult ICU patient advisory council, which really served as what we call a learning laboratory for us to test out strategies for using advisors and then trying to measure improvement. Then in 2009, we're somewhat unique in Massachusetts in that the state passed regulations said that all hospitals had to have hospital-wide advisory groups. So in addition to those advisory groups that we were already running, we then were happy to launch a hospital-wide advisory council.
How does this happen? Are there meetings, conferences? How do you pull these patients and families together at the same time with hospital staff?
As Barbara mentioned, over the past several years, we've developed 4 patient and family advisory councils, which come together several times a year for meetings. One council's for the hospital as a whole, one's for the adult intensive care unit, and one's for the neonatal intensive care unit. And then we have one for universal access, which works on making the hospital more accessible for people with disabilities. We also have patients and family members who are participating in hospital committees, such as our ethics committee, and we involve patients and family members in focus groups. Finally, patients and family members have been involved in process improvement events, which are based in a model called Lean, which is from the manufacturing world.
What are some of your quality and safety concerns? What are your approaches, and what are the solutions?
Quality and safety is woven into everything that we do at Beth Israel Deaconess. We are an organization that back in, I think, 2005 or 6, our then CEO created what was then called an audacious goal, which was to eliminate all preventable harm in our medical center. So again, it's something that we take very seriously. It's part of everybody's job and thought processes here at the medical center. When you talk about harm in hospitals and preventable harm, most of the time you hear about things like fall prevention, preventing deep vein thrombosis, preventing pneumonias and infection. But there's another element to harm, and that is how people experience the healthcare environment. People are not having good experiences, then that's another kind of harm. We look and involve patients and families in everything from our hand-washing initiatives to make sure that we are not spreading infections through inadequate hand-washing. We involve patients and families in how we get informed consent from patients and families. If there's been harm, how we talk with patients and families about harm and apology. All of those efforts have involved advisors in the process, so they are with the healthcare team and healthcare members thinking about how to improve the processes that would lead to better hand washing, better communication around harm and apology, better ways to inform people so that there truly is informed consent, and there's a whole host of other initiatives that we could go through. The advisors are woven into existing groups. If there's a group at the medical center that, again, is looking at our hand washing, and advisors then sit on those committees and in those groups that are looking at it. That's one way of advisor input. Another way that we obtain advisor input is already existing quality improvement groups come before the council, present their work, and come to the group with very specific questions on what they want to hear from patients and families. What feedback would be helpful to them as they think about doing this work.
And let's just take hand washing, for instance. I know so many folks, they're concerned to ask a healthcare provider to wash their hands, even though there's signs posted around the hospital. What is some of the outcomes of this collaboration, just say specifically about hand washing?
So as you mentioned, patients and families are often reluctant in spite of all of the campaigns, and we have the buttons that say, please ask us, which means please ask us if we've washed our hands. What we've come to observe is that patients don't necessarily do that. So what we would want from patients and families is to say, help us understand what gets in the way. And once we identify those kinds of barriers, so is it that you're worried that if you were to speak up, it would influence your family member's care? Well, what would help you to feel more secure? So we go through this process of, in some ways, deconstructing the situation and getting input as to what would decrease the barriers, and then incorporate that into our processes, and then try to evaluate, as we evaluate our hand washing, and we all have percentages of how well we're doing on this, is there any change based on the advice that advisors have given us? The groups that are doing this work then come back to the council or to the advisors to report back so that we close the feedback loop. So you've given us advice, we're going to go off and use it, and then we're going to come back and tell you whether we've used it, and we don't use everything patients and families say. It's not feasible, or it may not make our efforts move forward, but we at least make a commitment to them that we're going to give you some feedback as to whether we've used your advice, how we've used your advice, and whether it's made a difference.
Right. And with that in mind, how does the hospital staff feel about this kind of collaboration? So now you're taking these suggestions to the hospital staff and say, here's why patients feel reticent to ask, or here's what the families are saying. How does the hospital staff react to that?
It's often very eye-opening for staff. I think with the hand hygiene, just in particular in the ICUs, it became a real opportunity for staff to think about how they introduce themselves to patients and family members each time they enter the room, as hand hygiene was happening each time they entered the room. We've also heard from nurse managers working on other projects outside of hand hygiene realm who said that you gain a different perspective from patients. She said, we had all these ideas in mind, what's good and bad for patients, and we had good intentions, but we can't make assumptions about what patients want. And our chief nursing officer, who's a member of the hospital-wide Patient and Family Advisory Council, has said, at the end of the day, it has to be meaningful and it has to be about patients. And she's encouraged staff to be present and value what patient and family advisors bring to the table. So we have a lot of buy-in from top leadership as well as staff on the ground.
And I guess that would be the important aspect. If you've got buy-in at the top, it trickles down and then everybody follows suit. Well, folks, in the event that you are just joining us, you found the perfect resource for all of your healthcare and hospital safety concerns. This is Speak Up and Stay Alive Radio. I am your hostess, Pat Rullo. And today I'm so heartened to have these two lovely guests with us, Barbara Sarnoff Lee and Elana Premack Sandler, both quite instrumental in the Patient Family Engagement Project at Beth Israel Deaconess Medical Center in Boston, Massachusetts, where they work together to bring patients and family and the community into their hospital to offer the consumer voice to their efforts. So Let's go a little further with this. We now understand that the hospital staff is buying into this and they're happy to join in. How do the patients and the community react to this?
Well, we've heard really positive feedback, but one of the patients on our ICU council, when she was a patient, said that just knowing that a group like the ICU council existed made a difference for her and that it made her love the hospital even more. Another patient who sits on that council said that he was amazed at the extent of the hospital's commitment to this process of involving patients and family members and the fact that, as he said, they're willing to put their money where their mouth is.
And your website immediately lets the patient know that you are committed to patient education because on the very first page, on your home page, you actually have a tab titled Quality and Safety with subtitles that offer information about your quality efforts and efforts to improve quality and care, such as hand washing and infection control and the patient satisfaction experience, as well as another tab called Eye Health. And I just loved all the interactive tools and assessments and wellness and alternative therapies. And I think that this is what a hospital should aspire to. That's why I was proud to have you here. Well, since we are a national radio show, we've got people all over the country that listen. How would you suggest that our listeners outside of your area begin to approach their hometown hospitals to perhaps follow your lead?
People should have the confidence to ask at their local hospitals what ways they can be involved and whether the hospital has any opportunities for patients to participate in the design and delivery of health care. If they don't have any existing opportunities, the next question would be, would you consider starting? And if so, certainly if they are so inclined or curious, you can refer them. There's a national organization called the Institute for Patient and Family-Centered Care, which is a wonderful resource for both institutions, caregivers, and patients and families, and has a lot of material on how to start efforts at patient-family engagement. I think the key is to start small, and as we did with starting with a neonatal ICU council and then an adult ICU council, I think it's helpful to, again, start small, get some traction, and then think about broadening your efforts, as we did, to a hospital-wide council and then the involvement of patients and families. Key to this is having institutional buy-in, and if the organization is not open and willing to think about patient and family engagement, it's going to be very hard to start. But if they hear enough people ask about it, my guess is the organization at some point, their ears will perk up and they will take notice.
Well, good. I'm going to be on that campaign trail because I'm excited about what it is that you're doing. Where can our listeners find out more about you and what you do?
Our website is www.bidnc.org/PFAC or PFAC. And on that website, we have an e-newsletter where you can read about all of our patient and family advisors and the projects that they've been involved with all over the hospital. It's really been a pleasure to speak with you. We're really proud to be setting the pace for Massachusetts.
Well, I'm proud to have you here as well. So do you have any final words of advice for us today?
This is wonderful and exciting work, and I think it's the work of the future. So I encourage everybody to dip their toe in this water. And I would say engagement takes many forms. There's no one right way to do this. Figure out what way works for you and your community and your healthcare system and give it a whirl.
I thank both of you for taking the time to share your work with us today. I know I feel a bit more empowered to hear that hospitals such as yours are starting to include the voice of the patient and are openly offering resources to inform and educate the public. So please keep me informed, if you will, of your progress so I can continue to share this positive movement with our listeners. And I thank you both so much for being with us today.
Thank you very much.
Thank you.